So I'm very honored to introduce Noah Sher, a PhD, chief scientist at Mitochondria Therapeutics. She's going to talk to us about harnessing the power of mitochondria to treat rare diseases. The stage is yours.
So I'm here to tell you about the journey of one small Israeli startup company in the rare disease space and what the benefits are of working in this space. We're a mitochondrial company. We're working in the mitochondrial space. You probably all remember mitochondria from our biology lessons in high school, are the powerhouse of the cell, but they really do so much more. They are responsible for the homeostasis of cells, anywhere from proliferation to decisions to apoptose. And since every cell, or nearly every cell in our body, has tens or hundreds of thousands of mitochondria, you can imagine, in the beautiful slide I'm presenting here, that really almost every organ system in the body can be affected by mitochondrial dysfunction. And these can be dysfunctions of rare primary mitochondrial diseases, and they can be dysfunction that are associated with aging and many things that we will develop later in life. Okay. So Mitochondria has developed a technology called mitochondrial augmentation technology, and it's based on decades of study in the mitochondrial space. Basically, about in the 80s was the first time that it was demonstrated that isolated mitochondria have the capacity to enter cells, just as they did billions of years ago during evolution. And what we've done is taken use of this capacity of cells to uptake mitochondria and to transfer mitochondria between cells and utilize it from a medicinal point of view. Really, it's our belief that to treat really complex diseases such as mitochondrial diseases, we need complex modalities, such as cell therapies that were mentioned earlier. In our first clinical use of mitochondrial augmentation technology, we're using mitochondria to enrich hematopoietic stem cells that have mitochondrial dysfunction. And basically, we're harvesting autologous hematopoietic stem cells from a patient's bloodstream, isolating them, incubating them with mitochondria in a manner that allows the mitochondria to enter the cells and then reinfusing back into the patients. And when Nathalie Yves-Geoffran, our founder and CEO, first started the company, we weren't sure which direction we were going to go with respect to a disease modality. And then she was approached by a parent of a patient with Pearson syndrome. And despite the fact that she had been in the mitochondrial space for 20 years prior to that, she'd never heard of this disease. This is an ultra-rare disease. There's somewhere between 100 and 150 patients in the world. So really extremely rare, and you can imagine what that means like from a point of view of a parent to hear that their child has Pearson syndrome. It's a non-inherited disease. The mitochondria have a mitochondrial DNA genome, about 17,000 base pairs. Anywhere between 1 and 10 kilobase of this genome are knocked out in Pearson syndrome, and it's in different places in different patients, so there's extreme heterogeneity. As you can see on the graph on the left, the Kaplan-Meier, the prognosis is dismal. The patients die within the first 3 to 5 years of life, about 50% pass away, and the remaining don't reach past age 20. So it's a devastating disease with extremely different phenotypes. There are different levels of mitochondrial dysfunction in different organ systems in these patients. So one patient will have a liver disease, one patient will have a kidney disease, one patient will have a cardiac. You can imagine from a clinical point of view, how do you develop a clinical trial to look at all of these different phenotypes when you're talking about such a rare patient population? One of the benefits of working with Pearson syndrome as a strategy in the rare disease space is that we can learn as we go along. So developing a very complex therapeutic entity like a cell therapy really requires many iterations on drug product manufacturing, on analytical methods to do quality control on the product, and on the various aspects of clinical development. So the benefit of Pearson from our point of view, was to enable all of that with a small patient population, learning the things that we can assess during clinical trials and learning as we go along. It also affords fast-track opportunities with respect to discussions with the regulatory agencies as to endpoints. So with our first generation product, we were using mitochondria harvested from a blood unit from the patient's mother. And again, thinking about the risk-benefit for patients, there's a low risk. It's autologous cells. It's mitochondria from their own mother. That's what they were supposed to get in the first place if they didn't have the deletion. So it was a safe place to start. And we treated up to now 12 patients with that first-generation product, 7 under a variety of compassionate use requests for 3 different indications in the primary mitochondrial disease space, and 5 under a clinical trial, which was expected to dose patients, but COVID hit. It was expected to dose, 7 patients. We used as our primary endpoint an international pediatric mitochondrial disease score because we thought that would best capture the vast differences in the patient. So there were scores looking at functionality of GI and of neuro and of motor and so forth, so different phenotypes. And we did see both at the 6-month and the 12-month time point improvement in the IPMDS. We went to discuss with the FDA, and again, as mentioned earlier by Noam, really important to get the parent perspective and the patient's perspective. In the case of Pearson's, it's mainly the parent's perspective, but we did have with us parents of Pearson syndrome patients who actually also started a rare disease advocacy group. We had with us the physician from Cleveland Clinic who had probably seen the most patients with Pearson syndrome in the US. So it's really important to have that multidimensional discussion with the regulators because disease development, therapeutic development in the rare disease space is so complex. In the end, the FDA did not agree to the IPMDS because it is not a clinically objective, meaningful outcome, and it's so difficult to look at comparator groups in the rare disease space. Alistair mentioned it in this talk this morning. So what we did is we looked at the different natural histories that were published, and we saw that everything that 98% of the patients shared anemia as as one of the first things that the patients experience. And so we're looking to use that as our primary endpoint in the clinical trial. The FDA advised us, don't try to hit a home run. Don't try to look at survival. Don't try to look at all of the different organ systems. It's too complex. Look at a simple clinical trial. And what we're doing is to track other multisystemic improvements as additional endpoints. So just to give you a taste of the things that we've seen in the first patients we've treated, you could see on the left, top left, you could see the growth. We had many of the patients, a large percentage of them, showed improvement in growth, which is something that's really unheard of in Pearson syndrome. On the right, you can see the first compassionate use patient we treated. He was supposed to get a kidney transplant right before treatment, and we managed to postpone that for 5 years after treatment. His kidneys completely stabilized. And in the middle, this was the first patient I saw as a new Minovia employee about 6 years ago. This is a patient with Karen-Sayre syndrome, a different mitochondrial DNA deletion. She had daily epileptic seizures before treatment, and these completely stopped and stabilized after treatment. So again, different symptoms, different improvements. And what this leads us into is how do we take all of these understandings and think broadly, because one of the questions I get most frequently when speaking is, how can you make a business out of Pearson syndrome? It's 100 patients in the world. And so we're bridging out, and in addition to continuing clinical trials in Pearson syndrome, we're also looking at primary mitochondrial myopathies, because many of the patients have shown improvements in motor function on the one hand, and Pearson syndrome was our example of a mitochondrial DNA disease, a genetic primary disease. And on the other hand, we're looking at additional rare disease called myelodysplastic syndrome, but this is a disease of the aging population associated with the hematology side of things, but we have evidence showing that a lot of the disease is from mitochondrial dysfunction in the hematological compartment. So wrapping this up, Pearson syndrome kind of for us offered a dual proof of concept for bridging out to other diseases, and we hope one day it'll take us back to aging and to treat any mitochondrial dysfunction that we can identify in patients. Thank you.